Hi, everyone. Thank you so much. Welcome to the symposium. Let's see, Evolving Models of CF Care. I'm Dana Albon. I'm an associate professor at University of Virginia in Charlottesville. And I would like you to know a little bit about our symposium. This session will address different perspectives for models of CF care and future practice. And the speakers will address several very interesting topics. The role of remote monitoring technology, which is very hot right now. I'm sure you've heard a lot about telemedicine and remote monitoring. Applications for artificial intelligence in CF care. And anticipating the needs for an aging CF population. I know for sure, being an adult pulmonologist, that's something that I struggle with, and I have a lot of anxiety for what the future will bring. And to end our session, we have one of our patient family partners, Dave, Mr. Davidson. He will give his perspective on future care models. So welcome, everyone.
Thank you. My name is Jacqueline Davis. I am a pediatric pulmonologist at Boston Children's Hospital. And I have the pleasure of introducing our first speaker, Dr. Kathleen Ramos. She is an associate professor at the University of Washington in the Division of Pulmonary Critical Care and Sleep Medicine. Her research interests include advanced CF lung disease, access to lung transplantation, and clinical outcomes after transplant. Thank you so much.
Thank you. And thank you all for coming to this session and showing interest in it. And thank you for inviting me to speak today. My topic today is aging with CF and the role of lung transplant in the era of modulator therapy. This is my disclosure slide. I have funding from the CF Foundation. So today I'm going to talk to you about an update in CF epidemiology with respect to the aging CF population, as well as the changing healthcare demands of the aging CF population and lung transplant for the older CF population. So these are new data, hot off the presses, that we've seen in a couple of sessions over the past 2 days, that the median predicted survival age for children born between 2018 and 2022 has now increased to 56 years. And this improved survival guarantees an aging CF population. There's also improved lung function for adults, and it's improved dramatically over the past 20 years, with 18-year-olds presenting to adult CF clinic with normal lung function a majority of the time, and fewer than 2% come to adult clinic with advanced CF lung disease now. While this is fantastic, it is worth noting that the average age at lung transplant for a person with CF was around 35 or 36 years old in the year 2022 after ETI exists. So here are some projections. The European CF Society Patient Registry Study estimated that the number of adults living with CF will increase by approximately 75% between 2010 and 2025. And US CFF projections say that the adult population will grow to exceed 70% of the total population of people with CF by 2040 in the US. These are some CFF patient registry data that were presented in an abstract by Dr. Ali McIlvaney. And in 2021, in the US, in the registry, 4,586 people were greater than 40 years of age. There were high rates of hospitalization in this cohort, with a third requiring at least one hospital admission in 2019, and 36% experiencing at least one infective pulmonary exacerbation requiring IV antibiotics in 2019. And the exacerbation rate in this cohort did fall by 50% in 2021. There's increased participation in advanced education and employment. Among those over age 40 in 2021, 43% were university graduates, 17% had a master's degree or a PhD, less than 2% were unable to complete their high school education, and 42% had full-time employment, and an additional 11% were working part-time. And there are high rates of long-term relationships. 86% of those who are over 40 years old have either been married or cohabitating with a partner. So here's my crystal ball. Looking into this, I think that we'll be dealing with a much more complex patient population, with an increased population living with structural lung disease and chronic lung infections, and likely people will have even more prolonged survival with advanced CF lung disease. We're also going to see more CKD, chronic kidney disease, related to diabetes and growing in older age, and the IV aminoglycosides that we use. We'll also see obesity, cardiovascular disease, hypertension, liver disease. The increased risk of GI cancer is really important to mention and know about, and then older age at lung transplant. So as we look to the ivacaftor experience, the FEV1 declined more slowly at half the rate for the people who were ivacaftor treated with the G551D mutation compared to those who were homozygous for F508del. However, there does seem to be an age interaction, and the impact is less for people who are over 18 years old, based on data from Ireland. So this makes sense because people who are over 18 years old probably had structural lung disease at the time when they started ivacaftor. And so this decreased rate of decline over time is lessened. It's attenuated in the adults who were on highly effective modulator treatment with ivacaftor. So you might extrapolate that for people who are starting ETI as adults. So thinking about chronic kidney disease, or CKD and CF, with increasing age of the population and increasing prevalence of CF-related diabetes, CKD is likely to become a key complication for us to worry about and manage. In a CF cohort from 2001 to 2008, people with 1 to 4 years of CF-related diabetes on insulin had a hazard ratio of 2.4. They were 2.4 times more likely to have CKD than those without diabetes. And for people with 5 or more years of CF-related diabetes, their risk of CKD was almost 5 times higher than people without diabetes. And the prevalence of CKD increases over time. And so what you can see here in this USCF cohort from 2001 to 2008, the prevalence overall was 2.3%, but it doubles for every decade of age. And in a Copenhagen CF Center study, the prevalence was 2.7%, and it increased, the prevalence of CKD was 2.7%, and it increased with age, diabetes, and the use of IV aminoglycosides. Post-lung transplant, CKD can become a really serious issue. In this study using the CFF patient registry in a cohort of CF lung transplant recipients, there was an increased risk of CKD. There was a high rate of CKD with a 2-year risk of 35% among the lung transplant recipients. This increased risk for kidney injury after lung transplant is because of the immunosuppression medications that are used, which can cause CKD, and some of the medications can also worsen hypertension and hyperglycemia as well. And there's an age-dependent association with CKD after transplant. Compared to the recipients who are less than 25 years old, those who are 25 to 35 have a 1.6-fold increase in risk of CKD, while those over 35 have a 2.5-fold risk of CKD. So CKD is really important post-lung transplant, and it's also an important potential barrier to transplant as well. So switching to CF-related diabetes, in a European cohort, CF-related diabetes increased in prevalence by 10% every decade starting at age 10 years. And that's why we start screening for diabetes at age 10 years, is because of data like this. The prevalence was higher in females in the younger age groups. The effects of ETI on CFRD are promising, with multiple studies now showing improved glycemic control in the setting of ETI. But the weight gain due to ETI may muddy the picture, as the obese people with CF may have features of both CF-related diabetes, but also maybe type 2 diabetes. And so it becomes a little bit more challenging to know how to manage this complex syndrome. So between 2000 and 2019, the number of people with CF who were underweight decreased by 40%. The number who were overweight increased by 300%, and the number with obesity increased by 400%. And a quarter of the US adult CF programs have over 35% of their patients who are either overweight or obese. And these data were from before ETI was available. So the numbers are probably worse now. I mean, better that there are not as many people with underweight, but not good to have so many people with obesity. So hypertension is an adverse event that's associated with treatment with ETI. In the pivotal clinical trials, 10% of the participants had a diastolic blood pressure greater than 90 millimeters of mercury and a 5 millimeter mercury change in their blood pressure with ETI, compared to the 0.8% of the individuals in the control arm. So when you compare adverse events across the intervention and the control arm, that's how you can tell whether or not it's a truly associated effect. And so hypertension is noted on the package insert, the FDA label for ETI. So we should be thinking about that when we're seeing these high blood pressures in our CF clinic. There was a case series with 4 people, and it showed the onset of systemic hypertension within the first few weeks of starting ETI, and all of those cases needed to be treated with pharmacologic therapy for the hypertension. This is complicated by salt supplementation and the very high salt diets that people with CF tend to have, because they lose so much salt from sweating. And animal models also have noted in the past that CFTR disruption leads to lower vascular tone in the mouse model. And so you may think that correcting the CFTR dysfunction may increase vascular tone. So there have been recent case reports of ST elevation MIs and other cardiovascular disease in CF. And in a UK registry and claims database study, investigators used propensity matching to compare the risk of major adverse cardiac events, which included myocardial infarction, left-sided heart failure, or atrial fibrillation, in people with CF against matched non-CF comparators. And the people with CF had a higher risk than the matched general population comparators for major adverse cardiac events, with a hazard ratio of 1.65. In a study out of Johns Hopkins, coronary artery calcium score was abnormal for up to 20% of their patients with available CT scans of the chest, and they found that the coronary artery calcium score increases with age, and it's especially high. It's more likely to be present for people who are over age 50. And so now that we'll have more people who are living to be above 50, we have to be thinking about, do they have, similar markers to the general population who gets to be over 50 and are at risk for cardiovascular disease and coronary artery calcium abnormalities. And in a survey of CF providers, it was found that screening and treatment practices related to cardiovascular disease vary across CF centers in the US. These last 2 data points came from abstracts being presented here at NACFC 2023. So CF liver disease is present in up to 40% of people with CF, and severe CF liver disease has an incidence of around 10% by age 30. The main pathology is thought to be focal biliary fibrosis, and increasingly is described portosinusoidal vascular disease. And so managing long-term ETI therapy may become a challenge in the setting of evolving liver disease. The AST or ALT were greater than 3 times, 5 times, or 8 times the upper limit of normal in 8%, 2.5%, and 1.5% of people in the pivotal clinical trials. But interesting, the placebo group also had these abnormalities and elevated liver enzymes in 5.5%, 1.5%, and 1%. So the natural history of liver disease in CF may be a challenge, but it could be mitigated by ETI because it improves bile flow and bowel inflammation. So I wanted to talk about malignancy as well. People with CF have a 6.5-fold increased risk of GI cancers compared to the general population, and that was noted in a New England Journal of Medicine paper in 1995. In more contemporary data, people with CF have an increased risk of digestive tract tumors with a standardized incidence ratio of 3.5 compared to the general population. Post-lung transplant, the SIR for digestive tract tumors was shown to be 17.3 in this more contemporary study. They also showed an increased risk of lymphoid leukemia and testicular cancer in people with CF. In a separate study that compared lung transplant recipients with CF versus non-CF lung transplant recipients, the risk was elevated for overall cancer, as well as colorectal cancer, esophageal cancer, and non-Hodgkin's lymphoma, which is also post-transplant lymphoproliferative disorder, or PTLD, after lung transplant. And these SIRs are very, very high. So it's critical for people with CF to undergo routine cancer screening, and it's especially important after lung transplant. You'll note that all these studies that I'm citing here predate ETI, and whether ETI will reduce rates of malignancy is unclear given the role of CFTR as a tumor suppressor protein. But if ETI is going to lead to aging, and aging is associated with cancer in general, then we may find that there are different cancers that come up as we have this aging population of modulator-treated people with CF. So this slide here shows the publicly available data from UNOS, and the lung transplant recipient proportions by age category are shown in 2018, 2020, and 2022. And you can see that the overwhelming majority of transplants are in the yellow and blue pieces of the pie for people over the age of 50. Note that in 2022, you can see that 41% of lung transplant recipients in the United States were over the age of 65. So people with CF are generally transplanted, undergo lung transplant in the red, orange, or gray slices of the pie. As mentioned earlier, the median age at lung transplant for CF recipients was 35 or 36 years old in 2022, and the age at transplant for CF has been slowly increasing in recent years, but they are still much, much younger than most of the people who get a lung transplant in the United States. So we need to give appropriate anticipatory guidance and accurate information to people with CF about lung transplant. I think that we should not be telling people with CF who are adults with established lung disease that we can predict that they will never need a lung transplant. I think we are setting people up for being very disappointed and having incorrect expectations and feeling blindsided if they do end up with very advanced lung disease that could benefit from a lung transplant. For people who, for children who are starting ETI when they're 2 years old or at some point when they're 1 month old, it's possible that they might not ever need a lung transplant, but it's also possible that they may benefit from a transplant in their 60s or 70s instead of in their 30s. And I think that it's important for us to not overpromise on never needing a lung transplant because it can affect how people think about it for the rest of their lives. So fortunately, the older CF population is likely to have increased social support, They're having long-term relationships. They'll have more educational attainment and the possibility and opportunity to have adequate financial resources if lung transplant can be delayed by decades. And so there will be more complications surrounding lung transplant candidacy, especially CKD or chronic kidney disease. It can be a big barrier to getting a lung transplant, and that is why Stop 360 that we just heard about in the plenary is so very important, because if we can not give people IV aminoglycosides, if treatment of exacerbations is just as good when we don't give a nephrotoxin, then maybe we can preserve their kidney function and make it so that when down the road they might need a lung transplant, their kidney function will be better. So sorry, I digress. Anyway, they also may be more likely to have osteoporosis, cardiovascular disease, hypertension, and CF-related diabetes. And there may be the emergence of unknown potential contraindications that we just can't foresee yet. So in conclusion, there are a lot of unknowns and likely many evolving challenges to care for people with CF. The focus may center more on adult care given the advances in the care of children with CF, but I do think that messaging for the pediatric clinic is still critical to set people with CF up for success as they age. With all these high rates of comorbidities, it will be important for us to partner with PCPs so that we give appropriate standard of care treatment for their hypertension and cardiovascular disease and diabetes and all the things that we don't currently standardly manage in adult CF clinic. And then the lung transplant at an older age means more complexity, and it's important for us to counsel and provide early education about lung transplant, even in the setting of modulators, and important for us in the CF community to recognize that most recipients are older than 50 years old when they get their lung transplant in the United States. So there's still gaps in knowledge, and I have a few questions here. How should the care model change to address the aging CF population? How will lung disease progress in the setting of the current CFTR modulation, likely with still a large population with structural lung disease? What will the role of key comorbidities play in disease progression, and how will modulators improve or complicate them? And finally, how will outcomes change for older adults with CF who undergo lung transplantation? I want to thank you for your attention and thank Dr. Chris Goss for allowing me to shamelessly use and adapt his slides.
Thank you so much, Dr. Ramos. I have a question for the people in the audience who are not very familiar with cutoffs, and I know different transplant centers have different cutoffs. Could you talk a little bit more about what constitutes a cutoff and a contraindication to transplant in CKD? What's the creatinine or creatinine clearance, whatever you use at your center?
Yeah, that's a great question. So for CKD, it varies by center, and in the ISHLT consensus document for the selection of lung transplant candidates or recipients, we talked about if your GFR is less than 60, it's a risk factor. If it's less than 40, it's a high risk factor. So that 40 to 60 range is typically in the, it's not normal, and different programs will consider it differently. The big risk is that if you go into a transplant with already depleted renal function, you're at a high risk of needing dialysis after transplant. Like you could end up having a very complex postoperative course, and the medications that we give long-term also cause kidney injury for many people, and so you may end up needing a kidney transplant after the lung transplant. So those are some of the thoughts. There are acute concerns right after the transplant operation, and then longer-term concerns.
Yeah, and some centers have a creatinine of 1.5, which is not very high.
Yeah.
I have two other questions from the audience. One is, should people with CF post-lung transplant be screened for esophageal cancer?
Ooh, It's a great question. I don't know the answer to that, but I will say that based on the slide that I presented with the malignancy numbers, esophageal cancer is a much, much higher risk than the SIR compares to the general population. So the general population might be very, very low, but that is a high risk. I don't know of any guidelines that recommend screening for esophageal cancer after lung transplant, but yeah. Maybe we should be.
One thing more practice to consider is putting bundling the EGD
With, yeah. That's,
or if somebody has Barrett's, you ask for it more often. But certainly when someone's going to be put to sleep for colo, adding that EGD. But you're right,
I can repeat what Whitney said. So she said one way to think about that is maybe asking for an EGD when somebody who's post-lung transplant goes for colonoscopy, since they're already under the sedation. However, I think that's not commonly done right now. I mean, I think the number of people who miss their screening colonoscopies after lung transplant is tragic and sad, and we need to do better at screening people post-lung transplant for colon cancer. And I think whether or not to add an EGD is a good question.
We will take one more question from the audience. We have only 5 minutes between speakers. We will take more questions at the end. So, Jen.
Kathy, thanks for such a wonderful review. I appreciate it. Jen Gorelski from UNC. And honestly, looking at these slides, I am extremely intimidated, right, considering the number of patients that are going to graduate into our adult programs and the extensive amount of care that they are going to need. One question that is not necessarily directed at you, but maybe for all of us to think about is ways to actually partner with these PCPs, because given the vast majority of patients before this, they were in their 20s and 30s and they really didn't have any non-CF complications, right? And so they got used to calling their CF team for absolutely everything that happened to them. We were really good at it, but there's no way that I'm able to stay up on the hypertension guidelines and things like that. Not if I want to stay abreast of the CF care as well. And so how can we convince patients that it's important to actually get a PCP? And how can we convince the local PCPs not to be intimidated by these patients because they're like, oh my gosh, like I've never seen a 50-year-old with CF. And if there's any suggestions for that, thank you.
Yeah, I think finding ways to partner with PCPs is going to be really critical, and whether or not the care model actually evolves to have a general medicine person in the CF clinic, like we now have a GI doctor and an endocrinologist and ENT that are all very connected to our clinic. I think that the patient, the person living with CF perspective on this is that their PCP has to understand CF, because they don't want to have to go and explain their CF to another doctor. So I think if the CF Foundation could train some general internists to understand CF, that would probably be the right approach.
A lot of questions to be answered in the future. We're going to switch gears now, and I would like to introduce Lucy Gale. She's a senior... She's a senior research dietitian at University of Cambridge, and Dr. Floto, who is a professor of respirology at the same University of Cambridge. He's going to talk about, and I think together they're going to talk about artificial intelligence role in CF care.
Thank you very much for the opportunity to speak to you today. I'm not Lucy. Lucy's down there. We're going to swap halfway through. I want to share with you some of the work that we've been doing on imagining how AI and machine learning might transform future CF care. And we don't have any commercial disclosures, but we have received funding from the CFF. I didn't realize that was a disclosure, but we have, and we're very grateful for that. And I want to share with you two projects that we've been doing, both teaming up with world leaders in machine learning. The first, which I'll talk about, is understanding how we can use a deep learning approach to registry data to predict individual clinical trajectories, that is, say, risk prediction, time course of disease and potentially moving on to counterfactual estimations around individual treatment effects. And this is work done with collaboration with Mihaela van der Schaar, who's a kind of global superstar in machine learning. What Lucy's going to talk about is how we can use home monitoring data to predict acute exacerbations. That's work done with my PhD student Damien and with John Wynn at Microsoft Research. Okay, so we'll deal with the first of these. And so we've taken registry data. We've looked at the UK registry data. I just want to get your eye in and show you what that looks like. So this is data from 2008 to 2018, obviously pre-modulator introduction. And you can see the distribution in age. And as you'll all be aware, the increasing rates of complication as individuals with CF get older. So I'll just show you some of the complications that we focused on and how they change over time. So we've got lung function, impaired glucose tolerance, diabetes, allergic bronchopulmonary aspergillosis, death or lung transplantation, liver dysfunction, cirrhosis, hearing loss, chronic Pseudomonas infection, osteoporosis, and depression. So we've been able to model or develop models and algorithms to predict all of these. I'm going to focus on lung disease for the rest of this this talk. And one of the, Okay, so one of the problems of trying to model disease in genetic conditions is how to take over 1,800 mutations that can cause CF and input them into the black box algorithm. And so what we've done is we've taken data from CFTR2 and inferred the amount of CFTR dysfunction that each of the genotypes will cause. Okay, this is by looking at the frequency of pancreatic insufficiency when one of these alleles is in combination with a known minimal function allele. And so you can rank mutations causing CF from mild to very severe, and then look at how these complications change over time. We can see pancreatic insufficiency in the UK population nicely follows an increase as CFTR dysfunction scores increase, the same with diabetes to some extent, and the same with liver disease. But as you'll all be aware, lung disease is very different, and obviously there's an enormous environmental contribution to this. Other modifier genes have a big input. And so if you look at CFTR dysfunction scores and how that affects FEV1, you can see it's a total mess. And so the question we asked was, could a deep learning approach find signals in the data that would allow us to accurately predict what lung function was going to do in a future time horizon? So that's the first challenge for us, is predicting clinical outcomes. And as I said, I'll follow the lung disease theme for the rest of this talk. So it turns out that recurrent neural networks, or this flavor of it called long short-term memory, is incredibly effective at predicting the future FEV1 decline for individuals with CF. And you can see the correlation here between predicted and observed is very tight. And one of the things that Mihaela van der Schaar's group have been working very hard on is taking these black box models, and understanding how we can understand how the decisions are being made, so the interpretability of these models, and have developed a very cool, neat way to understand what the algorithm is using for each individual with CF. And so I'm showing you here the average, but for any person with CF, you can ask the algorithm, well, which features in the clinical data are you using in order to issue a forecast? And so you can see how the features are ranked on the left. At the top, the ones with the most average importance, this is for respiratory failure, and the ones at the bottom, how they change over years. Okay, so we're looking at the time zero, that's the time you imagine you're seeing someone in clinic, and then each year as you go backwards for up to 8 years. And so with this information, you can then start to ask, well, hold on a second, can we identify individuals not by their feature set at a particular point in time, but rather their predicted trajectory over time? And the answer is you can. And our approach has been to cluster patients based on a specific predicted clinical outcome, in this case, respiratory failure. If you do that with CF, you end up with 3 very distinct groups: low, medium, and high risk clusters. And you can see on this Kaplan-Meier curve, they're very separated. And indeed, if you look at this latent representation, you can see how for individual patients, they will move from a low to a medium to a high risk. Each of the stars is an individual patient. Now, you may be saying, well, this is trivial, because if faced with someone in clinic, you'd be easily able to tell if they were in which risk cluster. And the answer is, I'm not sure that is the case, because if you look at the features, they are overlapping between individuals in each of these cluster groups. So yes, there are significant differences in age, BMI, HbA1c, and FEV1, but with huge overlaps in each of these groups. So we believe that the potential of this kind of approach as a decision support tool may be very helpful in terms of distinguishing those people at risk of future decline. Obviously, this is pre-ETI. We want to see how things will develop over time once people are on modulators. So let me give you a case study then. For this individual, you can see the risk cluster assignment that the algorithm puts out at the top. So it goes from 1 to 2 to 3, the highest risk group. And you can see how days of IVs change, FEV1 decline change, and the amount of IV antibiotics change, and affecting the risk of respiratory failure. So you can see the algorithm is detecting a change in the features at this point here. Is my mouse coming up? Not really. It's not. Anyway, at the first point, and then it's issuing an increase in the risk score and based on the features that is detected at the bottom, and then another change later on, and it goes into the higher risk group. So one of the other things you can do is to understand what are the features that it's looking at in order to move from a low to a medium to a high risk by permuting specific features. So in the top, we can permute cough fractures so that no one has a cough fracture or everyone has a cough fracture, and ask how many people are moving from a low to a medium or a medium to a low group. And it turns out that actually with a cough fracture is a indicator or is used as a marker of a higher risk. And so here the Kaplan-Meier curves between those individuals with cough fracture and no cough fracture are very clearly divergent in the UK population. And similarly, looking at mast cell stabilizers, and permuting everyone to have a mast cell stabilizer seems to increase the numbers going into a lower risk group. And in fact, if you look at the CF-related asthma group, those on mast cell stabilizers have a higher mean FEV1 than those without. Obviously, this is association and not causal necessarily. Okay, so I'll conclude here and just point to the fact that we've begun to look at how deep learning analysis can provide decision support and potentially biomedical insight through individualized risk prediction and clinical forecasting. We want to see how we can develop these methods for use in clinical implementation, which will obviously require careful thought and evaluation. And now I'll just hand over to Lucy, my colleague, to talk you through the second half of the presentation.
Thank you. I'd like to talk to you about how we're predicting acute pulmonary exacerbations in adults with cystic fibrosis using home monitoring. So it's clear that there's great promise for artificial intelligence supported home monitoring in CF. There's enormous patient-led demand for change in the way clinics are delivered and clinical care is delivered. There's the potential to predict exacerbations so that we can treat exacerbations sooner. Physiological feedback to patients can help with adherence and enabling clinic only when it's needed. It could also provide relief for overstretched CF centres and enable safe withdrawal of treatments, and also reduce the risk of cross-infection. Also supporting virtual clinics with really rich physiological data. So I'm just going to talk you through our 12-year journey looking at AI-empowered home monitoring in CF. So we started off with Telemed, which was our pilot study, and then we moved on to Smart Care CF, which was our feasibility study, and which I'll talk to you more about further along. Then Project Breathe, which was our implementation and funded by the CFF in 336 adults in the UK. And now we're moving on to ACF, which I'll also talk to you about, which is a randomised clinical control trial in 400 adults in the UK. So thinking about Project Breathe, we've implemented this into clinical practice across large parts of the UK, and also recently we've opened in Ontario in Canada. So we, for Project Breathe, asked patients to record using home monitoring equipment, which is small and handheld and Bluetooth enabled, and it links up via Bluetooth to an app on their smartphone. So we asked them to measure spirometry, their oxygen saturation levels, their weight, temperature, and complete a symptom diary. And this can then feed through not only to their app, but also to the clinical teams, and also in a link and anonymised fashion to researchers for analysis. So we've already seen a big impact of Project Breathe in clinical practice. There's a positive impact on lung function and a reduction in the number of IV days. It's overwhelmingly acceptable to patients, and they feel much more empowerment because they have more information in order to give them control over their decisions. This is a quote from one of our patients who took part in Project Breathe. Thank you, Team Breathe. You've been almost as important as Kaftrio in transforming CF care. So if we just take you back now to Smart Care, this is our feasibility study in almost 150 adults with CF across 7 CF centres. And the participants were enrolled for 6 months. They were asked to do daily home monitoring, as I've described previously, and also a symptom diary and a daily sputum sample. So shown from these diagrams here, most of the patients did most of the measures on most of the days, which is great. And we had a number of exacerbations during the study period, which is shown on the right. So if we compare conventional clinical measurements, where, for example, when you see somebody in clinic, you do their lung function, and you'd only do their inflammatory markers such as CRP when they're unwell. And we compare that to the information that we can have when we use home monitoring. We have a really rich data set. So here we've got lung function, oxygen saturations, pulse, activity, their weight, temperature, cough, wellness and sleep. And there's sufficient signals. And what we're looking for is this area in red, which is the period before an exacerbation starts. So have we got sufficient data to predict a future APE or an exacerbation? So then we started thinking, well, what does a typical exacerbation look like? And decline is the decline is halted by treatment. So it could look different as to whether they have IVs here, 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 or here. So by aligning the data windows of the signal, we created a typical profile. And this is across all of our measures. So FEV1, oxygen sats, everything I've previously described. And here is a typical an exacerbation where there's a decline, then there's some improvement in parameters, and then there's a terminal decline until treatment is implemented. But then we started thinking, well, are all exacerbations the same? So we grouped the exacerbation signals, and in this case, we came up with two curves, group 1 and group 2. And then to give you some more detail, we've come up with 3 classes of exacerbations. So the one that I've just described, the more typical one, class 1. Class 2 is where there's a decline and then some improvement. And then class 3 is where there's a terminal decline until treatment is implemented. For clarity, we've just put here FEV1 and wellness. And those are the classes that we've come up with. We also then looked at clinical features, and in each of these exacerbations, we can now say that those in group 1 have higher Pseudomonas, those in group 2 have reduced inflammation and reduced CRP, and those in group 3 have an increased requirement for IV antibiotics. So if we're then going to look at predicting exacerbations, what we want to do is to run the predictive algorithm and to see here there's 2 traces from patients. Now they're very noisy, but actually the algorithm was able to detect when the exacerbation was going to take place. And we then ran the same algorithm with patients who were on ETI therapy, and despite the fact that the trace was very different and there wasn't as much noise, it was less volatile, it was still able to accurately predict the onset of an APE. So these diagrams here show the performance of the algorithm, and it's pretty effective. And we think that we can detect when someone's going to get an APE about 10 days earlier than conventional care. The diagram on the right shows that actually the prediction is most effective when we use all of the parameters. But if you draw your attention to the columns on the far right, actually FEV1 doesn't have as much as a contribution to this as you might have thought. And we think that is because FEV1 changes quite late in an exacerbation. So now moving on to our latest trial, which is called ACF, Artificial Intelligence to Control Pulmonary Exacerbations in CF. So this is a randomised clinical control trial with 400 participants that we're aiming for across 8 UK sites. And patients will be randomised 1-to-1 to either see home monitoring data, as the previous trials that I've shown you, or they'll be randomised to see the predictive algorithm as a traffic light. So either green, which means you're doing great, carry on. Amber, we can detect some decline in your health parameters, so please try and maximise your treatments. And red, an impending exacerbation, please contact your healthcare team for a review. They might also get a white colour, which means that we haven't got enough data for an accurate signal, so they'd need to do some more home monitoring. So just to illustrate here, conventionally you'd get a call from a patient in between regular clinic visits. With home monitoring, you can have an algorithm alert in between, that's monitoring in between telephone visits and virtual visits, and detecting the exacerbation sooner. We feel that there could be a huge cost saving from using this approach of an estimated £30 to £40 million per year, and that doesn't include lots of things. We're looking at the health economic impact during ACF. So in conclusion, we feel that AI-empowered home monitoring is effective at detecting exacerbations earlier than currently, that it may allow early non-medical intervention to protect long-term lung health, and it may provide a cost-effective solution. Machine learning algorithms provide trustworthy recommendations for personalised risk scores, individualised treatment recommendations, and personalised health forecasting. I'd like to thank lots of people who've been involved in all of these studies, and particularly Damien Sutcliffe from the Floto Lab, Michaela van der Schaar from the Cambridge Centre for AI and Medicine, John Wynn from Microsoft Research, Kirsty Hill from Magic Bullet, all of our patients and participants and our research teams. Thank you.
Thank you both to Lucy and Dr. Floto. Happy to take a question from Dr. Sawicki.
Yeah, thank you for a really incredible presentation of an incredible body of work. I have actually two questions. The first is when you're thinking about machine learning and harnessing big data for predictions and clinical prediction and helping clinicians, how much data is sufficient? How much is too much? How much is too little? And I think from the point of view of myself as a pediatrician, I'm not going to have a lot of data on a 2 or a 4-year-old. Do I have to wait for a child to grow up to be 10 and have 10 years of data on this child in order for these algorithms to work? Or will it be different for different age groups? Because people will obviously shift over time.
Sure, I'll take this one. So that's a great question, and I think it depends very much on what you're looking at. What I would say is that one of the problems with machine learning predictions is that you have no sense of uncertainty, and so it just gives you the answer that is the best that it can find, but it doesn't tell you how good, how certain. And so one of the things we've been working with a lot is in terms of uncertainty estimation. And so obviously with more data, you'll have closer, less uncertainty. But it's a great question. Yeah.
And then my second question about Project Breathe, it sounds like you asked people to monitor a fair number of things using a fair number of devices. And I think our next talk is going to talk a little bit about home monitoring as well. But you show data that people actually were able to monitor or were able to provide this data. Did you get a sense from participants about how easy or hard it was to be able to, in addition to balancing their lives and their treatments for CF, also think about these 6 devices that they all had to provide data for?
Should we take this? Sure. All right. Well, since I'm starting here, I don't want to say, okay. So yes is the answer. So obviously for the trials, we were very keen for them to do as much data as possible. It turns out how much data is sufficient, and it turns out that you probably get a pretty robust algorithm outputs from about 3 times a week. So actually the burden is much less than during the trials. That's always a balance, and I think in stuff we haven't talked about, we've been moving to sensors that are more passive because obviously that's more effective. Spirometry was the one thing that everyone hated doing. So
Thanks.
Can I just add something?
Go ahead.
Can I just add something to that? That actually, once the equipment's been set up with our research team, because it all links up automatically via Bluetooth, it just takes a couple of minutes. I know it's still a couple of minutes, but it is actually very, very slick.
Thanks for that presentation, Theta Ong from Seattle Children's. Is there an intention to build into any of these predictive algorithms as you're applying them to the various populations to investigate by race, ethnicity, opportunity indexes? And is that part of your continual model at the source of the data, or is that more on the back end in terms of the evaluation?
Can I say that one? Yeah. So that is a really great question. We are limited in the UK by overwhelmingly white population with CF. And one of the critical questions we need to ask is how generalizable this is. I think without doing specific trials to address that and to recruit specifically from all ethnic groups, I think it's going to be very hard to be confident about whether this is generalizable or not. So great question, yeah.
Great, thank you so much. Next, we will hear from Dr. Whitney Brown. Dr. Brown is the Senior Director of Clinical Affairs at the Cystic Fibrosis Foundation. Before that, she worked as part of the ANOVA Advanced Lung Disease and Transplant Program and started the ANOVA CF Center. Currently at the CF Foundation, she focuses on supporting the CF Care Center network and advancing the CF care model. Thank you, Dr. Brown.
Thank you, and thank you for the invitation. Let me pull up I just want to say I'm really impressed on a Friday afternoon that so many of you are here. And I hope to keep you engaged with what I think are some of the most awesome study acronym names that we've heard in a while. And I invented none of them, but they're very good. Do you need to do it? Okay. Okay. Here we go. I have no relevant disclosures. So over the last few years, we've seen a trend of less in-person clinic visits. And to explore care outside of the traditional clinic setting, we will discuss today some components of CF care that may lend themselves very well to being done remotely. We will review studies in progress to answer some of the really pragmatic questions of how these remote tools can be incorporated into routine CF clinical practice. So this is a summary of some of the components of CF care, and certainly not exhaustive, but it provides a framework for us to consider which of these may be addressed remotely to complement standard in-person practice. And the items bolded are elements that lend themselves well to home or being done near one's home, and certainly there may be many others. And in the box here, I've highlighted some key questions to consider as we advance remote CF care. What can be done remotely? How do we gain greater confidence in data that's gathered remotely? And how do we incorporate that into routine clinical care outside of a research study? I want to mention that I'm presenting today on behalf of these funded study teams, which we're calling the Tools for Remote CF Care Study Teams. So in 2022, the CF Foundation issued a request for applications to study remote tools in CF. These 6 multi-center study teams are being funded to study their topic of interest in a real-world quality improvement manner. And these teams have great broad geographic representation and program sizes to really understand how these tools will work in a variety of settings across the country and potentially across the world. And you can see that these studies fall broadly into 5 categories: home spirometry, acute sick visits, home cultures, coordination of remote testing, and social determinants of health. And I'll use this as an outline to walk through these studies. So when it comes to home spirometry, we know that it was really launched quickly during the pandemic, but many patients now have experienced using home spirometry in some fashion around the world. And we know home spirometry can be used as remote monitoring, like we saw previously, where data is coming in at regular intervals from patients. It can be used just coupling it with telehealth visits to enhance the quality of those visits. And then it can just be utilized when patients are sick. And it can be done as a coached spirometry via a telehealth platform with a respiratory therapist present, or it can be done independently. But because home spirometry was launched so quickly by necessity during the pandemic, there was not time to establish best practices and slow down and see what we need to do to optimize this moving forward. These 2 multi-center QI studies are attempting to answer some of those questions. Both are focused on the pediatric setting. And the first study, iCups, is designed to increase knowledge of spirometry among patients and families on the use of home spirometry, and then also to really incorporate training on the home spirometer and how do you integrate data into the clinic workflow. The second study, iSpy, is focused on the quality of that spirometry and how that might compare to the PFTs that are done in clinic. It also seeks to look at barriers to the use of home spirometry, both from the provider side as well as the patient and family side. Both studies are currently enrolling at the CF programs listed there, and I think both are really working hand in hand with people with CF and their families to continuously improve their processes as they go. So we know that one of the applications of this home spirometry is the evaluation of pulmonary exacerbations. So these next set of questions relate to how we evaluate patients when they notify us that they're sick. And we know that distance from the care center and appointment availability can be quite limiting and delay the prompt evaluation and treatment of care. Telehealth sick visits may facilitate faster initial evaluation than coming in person to clinic. And arguably, telehealth may be better than making a decision over email or phone call. This group, Europa, led by Dr. Noah Lechen, is using an algorithm to study these telehealth sick visits. This algorithm incorporates home monitoring to include things that similar to the AI, vital signs, spirometry, and remote respiratory culture collection in concert with the telehealth visit. And the primary outcomes here are looking at the feasibility of doing a telehealth within 48 hours of notification, the feasibility of collecting the data to enhance the quality of that visit, and a successful follow-through with the treatment plan, as well as a follow-up visit within 6 weeks. And speaking of remote collection of cultures, it can be helpful with the pulmonary exacerbations as being studied by the Europa group, but also in routine surveillance. So the current clinical care guidelines, as you know, recommend 4 respiratory cultures a year. And we know this is particularly important for the initial detection and eradication of Pseudomonas. However, we also know that this is increasingly challenging in adults and children on ETI who are attending clinic less often. And these are some of the key questions we consider when we think about if and how oral pharyngeal swabs could be obtained at home and mailed in for culture. So the SwabIt team is focused on the home collection of OP swabs, and specifically to find out, is it feasible? How did the results compare to swabs done in clinic? And how are the culture results integrated into clinical decision-making? And this study is obviously very heavily dependent on input from patients and families, because truly getting swabbed by your partner or your parent is a new form of family bonding. But enrollment is going really well, and they did a preliminary data analysis just last month of their first 30 samples and determined that their process was working well, and they're going to continue to move forward with the same protocol. Their enrollment goal is 180 by the end of November before they roll into phase 2. But we know with the incorporation of remote tools into CF care, more responsibility falls on people with CF and their families to cover these components of care outside of clinic. And there are many ways to potentially help individuals organize their remote care and reduce barriers to completing their CF-related tasks. A well-designed phone app may be such a tool to help provide reminders and goals that could facilitate remote testing and self-management. And here are some of the key questions to consider when we think about such a phone app. So the CF at Home study is using a mobile coaching app to help individuals coordinate self-monitoring, and performance of recommended screening tests, looking for CF-related complications in spite of coming less often to clinic. And this study incorporates home spirometry and weight at regular intervals, but also when patients are sick. And it offers optional remote testing, and that includes sputum collection, routine CF labs, oral glucose tolerance test, and DEXA to be done in near home if desired. The goal is to assess how patients interact, how often they interact with the phone app, what is the satisfaction from both the patient and the provider side, and impact on screening rates. And this app was designed specifically for this context with input for adults with CF and is easily downloadable to a smartphone. As we know, there's an increasing movement to screen and address social risk factors as they impact health outcomes. Many CF programs have integrated this into clinic flow, but with less clinic visits, how can we make sure that we are reaching those who may be struggling with life issues and potentially to the point where they can't make it to clinic? there may be an opportunity to connect with individuals outside of in-person clinic visits and screen and provide necessary assistance when available. Here are some of the key questions that come to mind when we think about screening and intervening. And not listed here, but of course, critical to any screening in any setting is the development of trust and established relationships. The illicit group is studying the feasibility and sustainability of screening and addressing social risk factors remotely. The goal is to address these risk factors for people with CF and increase access to care. And they have a mix of both adult and pediatric programs around the country to test this in a variety of settings and patient populations. They will be starting enrollment soon. And this is particularly timely here in the US because we know that the Center for Medicare and Medicaid Services will be requiring hospitals to begin reporting on social determinant screening rates starting next year. And this may be an opportunity for the CF community to really come out as a leader, as it often does. So in conclusion, in the post-ETI and post-pandemic era, clinic visit is clearly decreased for many individuals with CF. And tools for remote CF care may help maintain a connection between care teams and patients and families so that health outcomes are not only maintained, but potentially improved. But partnership is a key component of care as it may shift from being completed in the clinic to some being completed at home. And certainly this rate represents a trade-off for patients and families, as this is going to require more effort in between visits, but potentially less time and less frequent visits to the CF Center. Some patients will be more interested in doing this than others, and we have to recognize that this should be individualized. But we are excited about the 6 multi-study teams that are using QI methodology to study these tools in real-world settings. Oops. And we look forward to presentation next year. This time, it won't be me up here, but it'll be these 6 groups telling us about the innovative ways they've been able to make progress in these areas. And this, in conjunction with a lot of the work being done by you and others in the community, will help us continue to adapt CF care to meet the needs of everyone. Speaking of adapting CF care, if you haven't had the opportunity to complete this survey, this is a survey that we've designed to hear from both care teams and patients and families, same QR code, to hear input on what people need, what they want, what they believe is the value of coming in person, what they'd like to do potentially outside of clinic. And again, we're really going to use this input to adjust the care model as we move forward. I'm going to keep it for 5 seconds to see if somebody will scan for me. Thank you. I'm not moving on until someone scans. No, thank you. This is also available in the exhibit hall at the CFF booth. So if you forget to do it now, please do it later. Now with that, I really want to thank the teams that are doing this work, commend their partnership with people with CF and their families as they've co-designed and are co-managing the portfolio. And I'm happy to take questions, or I'm even happier to pass them off to the investigators, many of whom are in the audience. But thank you. I'm going to leave this up here in case you need to reference one of the studies or look at the cool acronyms.
Please enter any questions you don't want to ask into the app. We're happy to ask them for you. We have one question. What is the reimbursement rate of remote monitoring?
Well, that is a good question. And I think something that it continuously changes over time and it's hard to keep up with. But in fact, at the program directors, U.S. program directors lunch today, someone did raise their hand and say, this is great that we're innovating the care model and that we're meeting patients where they are, but what about our clinic revenues when we do more of this outside of the clinic? And obviously the care teams need to remain intact. They need to remain supported by their institution. So we know that during the pandemic, telehealth reimbursement was pretty wide open and you could do it across state lines and licensing was suspended. I mean, the licensing was open state to state. Now telehealth is still being reimbursed pretty close to prior rates, but the licensing restrictions from state to state are back on and there's other struggles. And our policy and advocacy team at the CF Foundation continues to advocate strongly for improved coverage of telehealth and also for reducing barriers or removing the state licensure as much as possible. The remote monitoring, where data flows in and you interpret it, it is billable, and home spirometry interpretation, for example, is billable. The performance by an RT can be billed if it's coached and live, and also the interpretation can be billed. But I think we really need to help organize. Most teams won't know where the billing codes are. It's extremely hard to set up new processes. So as we move into this space, we're going to need to really organize and channel the information that we have to keep it sustainable for the care teams. But good question.
We can take a question from the audience.
Thank you, Whitney, for the great summary. And you mentioned all these teams are working with families and patients and building that collaborative approach. And I was thinking, you mentioned the word trust, and I've had conversations with Cindy George about that. Is there a way we could, and the PEP program has been great about teaching us how to do that. Is there a research approach that we can learn? What's the best approach that we can do to build trust with our families and get them to really partner with us?
Great question. I wish I had the perfect answer, but I think a lot of it is based on building relationships in the time that you have known, the time that you've known a patient and their family. So, for example, we're talking about this remote monitoring and telehealth, but there's likely periods of time during life, like a new diagnosis or when an infant is born or transition to the adult program or to transplant, where this monitoring is really not the most appropriate way to take care of someone, that you do need to be seeing patients in person frequently, sitting across from them to work on building that trust. I think it's incredibly hard, for example, to have the first initial consult visit when you're accepting a new patient be via telehealth and then expect that you're going to connect from that moment on. And so I think recognizing that trust takes time, it may be more quickly developed in person, but I think that regularity of visits during critical periods in life are really key to building that. And once you have the more established relationships, then we can really think about things like screening for social determinants of health and asking about not being able to pay bills and not having enough food to eat over telehealth. That just doesn't happen organically without knowing someone. So excellent point.
Thank you.
So, Mike, I want to answer a little bit to your question. I love it. So we do a lot of telehealth, as some of you know, at UVA. And, part of the PEP program is teaching you how to start the conversation in the visit by talking to something that's not necessarily CF related. And I have to tell you, I love seeing my patients through telehealth. Sometimes I see their spouses, sometimes I see their pets, sometimes I see their children. And they wouldn't bring the pets or sometimes spouses or even the children to the clinic. And I can establish a completely different relationship and relate to them in a completely different way. They love that I don't have a mask on my face, that I don't wear a gown, that they can see me and see me smile. So I think there are pros to seeing the patients in their home environment.
I think that's a great point. And oftentimes patients and families feel more comfortable in their own setting as well. If everybody isn't familiar with PEP, that's Partnership Enhancement Program, which is a program offered by the CF Foundation. It's usually a sort of 8-hour, one-day course that you take with your care team. They'll even come to your care center to really work on communication tools and knowledge about how to partner with patients and build trust and what things as we communicate, what intentional or unintentional messages we may be sending. So it's an excellent program. There's also a virtual option as well, in the spirit of virtual and in person.
I'm not sure I have a question here, but I think it is just worth recognizing too, as we think about remote monitoring opportunities, they often require internet
Yes.
and tech savviness. And so we do need to make sure that we're making sure this is available in an equitable way for our CF patients. And I know, at least the project I'm involved in, we are considering that, but I just encourage everyone to think about that if they're involved in this work too.
Right, absolutely. Other questions or comments? Thank you.
Thank you.
I would like to invite Mr. Davidson here with us. Yes. So initially we planned to have Juliana. She's in the audience. Juliana Bailey is a dietitian, and right now she's in Melbourne, Australia. And I would have loved to have her here with us. But she has laryngitis and she cannot talk. So I would do the best I can to fill her shoes, which I think they're big shoes to fill. But fortunately, I have known Dave also for the past 4 years, Juliana for a little bit longer, as part of the network leadership team, where we are team members together. And I want to say I'm really appreciative for you volunteering and giving your time to CF Learning Network and to the NLT team. I really appreciate that.
Thank you.
And thank you so much for coming here and talking to us today about how, changes in model of care in CF influenced your life. And I want to start by asking you to tell us a little bit about yourself.
Okay. Well, again, my name is Dave, and I am 62 years old, have cystic fibrosis. I am married. My wife and I, at the end of this month, actually, will have been married for 32 years. And thank you. And we recently became grandparents last Thanksgiving, so we've got a little granddaughter, and it's amazing how you can instantly love a little person like that. It's wonderful to have. But we have, what else can I tell you? We live in Council Bluffs, Iowa, which is basically a suburb of Omaha, Nebraska, and my CF team, several of which are here right now, at the University of Nebraska. So it's good to see them. No heckling. But we have a dog that is basically our second child. She's a 7-year-old Bernese mountain dog. So she's a great dog. Love that dog. But anyway, my wife was supposed to be here today, but we had a little family emergency and she stayed home to help with that. But yeah, I'm glad to be here. I appreciate the invitation, Dana, and I'm ready to answer your questions, I guess.
So my next question, or Juliana's next question, mine too, is could you tell us a little bit about your CF experience through life and anything that you can share that you think would benefit other people with CF and all these, care team members to take care of patients with CF?
Well, my experience with CF throughout my lifetime, how much time do we have? It's hard to cram 62 years into just a few minutes. So I'll hit the highlights. And if anyone has any questions at the end about any of it, please let me know. I'm usually not comfortable speaking about the experiences that I have because I don't like people to feel sorry for me or pity me or anything like that. So I try to hide it, much like I did as a child. But to get on with it, sinus problems have always been the major part of CF in my life. From my earliest years clear through to even now, I've had a lot of sinus issues. I've actually had 30 sinus surgeries. That's 30, not a typo. But I was always having infections and having to do medicine treatment, going to the hospital. As I was growing up, I had a lot of breathing problems. I couldn't breathe as well as my friends and couldn't keep up with them. And as a child, I thought it was something I was doing wrong because I had not been diagnosed with cystic fibrosis at that point. So I thought if I just worked harder, I could do all the things that they did just as well as they did. But around age 12, I started getting polyps. And of course, that involved more surgeries. And I was seeing my ENT doctors every 7 to 10 days to get a debridement. And that's been for years that's had to happen. Let's see. Sinus problems.
Those are a lot of ENT visits.
Yes, it is. It's a lot. And I was doing sinus rinses myself 3 to 5 times a day. So it was a lot. When I was 33, my ENT doctor sent me up to Mayo Clinic in Rochester, Minnesota. He said my sinuses had become so damaged from the surgeries and the infections that it was too dangerous for him to do, and I needed to see someone with a little more specialized training in difficult cases. When we got up there, we were talking to the doctor and going through medical history, and he asked me if anyone had ever talked to me about cystic fibrosis. And I said, nope, I never heard of it, don't know what it is. Needless to say, he tested me, and sure enough, I had CF. So the next day in his office, when he was going over that, to me, my initial reaction was relief because I realized all these health problems were not my fault. It wasn't something I had been doing wrong. So, but along with that came the reality of a CF diagnosis and all the implications of that. So it was kind of a good thing, bad thing, if you will. But after that, life continued, still seeing the ENT every 7 to 10 days and doing, having to deal with all the infections and everything. And then in 2009, surprise, I had pancreatitis. And I kept getting pancreatitis more and more frequently to the point where I was in constant pain. And we were trying everything to find a correlation. Was it something I was eating, how much I was eating, when I was eating, just all sorts of things. And I had been diagnosed with a micro-sized sludge-filled gallbladder, so they said, well, maybe if we take that out, it might get rid of the pancreatitis. It did not. But this went on for 5 years. And my health had declined considerably. My FEV1 had dropped down to 28%. And I had to quit my job because I was in the hospital so much with pancreatitis. Excuse me. And in 2014, they mentioned a total pancreatectomy with auto-islet cell transplant. I thought they were crazy, and how could that even be? And can you live without a pancreas? And I refused. But later that year, I said, I can't keep going the way I'm going. So I went ahead, agreed to the surgery. April 14th of 2015, I had that surgery. And supposed to be in the hospital for 7 days, ended up being 31 days because it didn't go too well after the surgery. I ended up with pneumonia. My one and only kidney got damaged, and I woke up one day realizing I was having dialysis. And so that was kind of a shock. But for the first two and a half weeks, I just really just had little snippets of consciousness, if you will, just little snippets of remembering things and what was going on with me. But it was a very, very difficult time, and I almost died. So, but after that, one last thing. In 2021, just 2 years ago, the infections in my frontal sinuses were so bad they were concerned it was going to go into the lining of my brain. The MRIs were showing some definite issues, and they removed my frontal sinuses. So, of course, if you don't know how that's done, they cut you open from ear to ear and then remove the front of your skull to do that. So that was a little traumatic, but thank God my hair grew back. So,
It sounds like you've been through a lot. I'm so sorry you had to go through that. How often and how did you establish care with your current CF team, and how often would you see them? I can't even imagine like having so many doctors' visits between ENT and probably gastroenterology, and then your post-transplant team and your CF team. Can you tell us a little bit more about that?
Well, I started seeing the team at Nebraska probably 6 months after my CF diagnosis. I didn't know there was a CF clinic in Omaha. One of my trips up to Mayo Clinic, they did mention it because that was a 5-hour drive each way and usually involves spending the night. So, and I actually started at Nebraska about the same time Dr. Murphy did. So we instantly kind of bonded. We had that common new thing to share. And, you know, the Nebraska team's just been wonderful. I actually consider them more family than anything. So.
Yeah, I want to share this. I consider my patients my family too, and I'm a grandmother too. I have I have patients who are grandmothers, and I have their baby grandchildren on my board. I love that. So even though I'm not at an age, hopefully you realize that, where I'm a grandmother. So the next question is, how did ETI or did it change? Are you eligible? I've never asked you this. Can I ask you this?
For what now?
For ETI, for the Trikafta.
I am on Trikafta, and
Wonderful.
it has been a life changer. So for those people that are able to take Trikafta and actually stay on it, you know, they're not having issues with the side effects or anything, it's been a life changer. I have not had to be hospitalized for CF in a number of years, or I've at least refused to be hospitalized. But you know, I actually quit Trikafta for a month because I was having an issue and we didn't know if it was related to the Trikafta. And it was so amazing. One day, I was outside working and I started coughing and I was having difficulty breathing, and it's like, oh yeah, this is what CF is like. Yeah. So yeah, Trikafta makes a big difference, and I'm very thankful for it. But I know it's created kind of some scrambling in a lot of ways because, well, how often do we need to see our patients now? Now we have weight problems. Quit looking at me. But, you know, there's a lot of other things now that we have to be cognizant of with Trikafta.
Did you discuss with your CF team how Trikafta will change the regularity of your visits, or if it changes? Have you had that conversation at all?
We personally haven't had that discussion with me because I don't, you know, I'm close enough that I don't mind going in for my regular visits, and I like the person-to-person look them in the eye kind of a visit. I think that where there is a need and a place for telehealth and even artificial intelligence in healthcare, nothing beats the face-to-face interaction that you have with your healthcare provider and just their intuition and their knowledge of you and being able to look at you and catch little subtle nuances in that personal visit, I think are extremely important.
I have to tell you, some of my patients think like you. So what would you tell a patient? This is a question that, you know, I'm asked a lot. So, doc, I'm doing so much better. I don't think I need to see you in 3 months. So if you were me, what would you tell the patient?
Ooh. Feel no pressure. You know, it is hard. CF encompasses so much of your life, even daily care. You know, it's hard if you're feeling good to go in and do that appointment. But you never know, you know, what may be brewing. And it's good to get that clean bill of health. And it never hurts to, as I say, do that one-on-one, face-to-face interaction with your doctor.
I love your answer. And that's exactly what I tell my patients too. No offense. If you tell them something else, no judgment here. But I tell them the same thing. Like, I understand where you're coming from. I understand that you're feeling very good, very well. And I understand your desire not to see us every 3 months. But the data right now, it's insufficient to tell you not to come every 3 months. And I would love my controlling me. That's how I tell them. My controlling me wants to see you every 3 months so I can get that sputum or you know, swab, like swab it, whatever information I can so I can give you that information back to tell you how you're doing.
Yeah. And I've even been offered taking home the little cup and providing, you know, the sputum at a later date. Like, you know, if I produce some, then I can just keep it in the fridge and take it. Well, my wife has a problem with a cup of sputum in the fridge, so.
I know some patients, you know, even in front of me as the physician, they have trouble and issues coughing and producing that sputum, even though I tell them sputum for me is like gold. Like, not that I love sputum, but sputum is gold. I really love having it in clinic if I can. Anything else out of your wisdom of being 62-year-old? Like, what do you think other patients should look forward to, like, as aging with CF? Anything that you can share, you know, about how life is moving forward and what to be looking for?
Well, getting older is actually an advantage to aging with CF. But what I would say is, you know, and a lot of the things that come to mind have already been talked about today, and I really appreciate the attention to those. I would say, as you age, there's other comorbidities that you have to be aware of, just typical aging things. But how do those play into having CF? So it's always a good thing to have a primary care provider that's looking out for you and that works well with the CF team. My ideal CF care model as we get older is to have a fully functional, very integrated team of subspecialties that work together with your CF team. You know, gastroenterology, endocrinology, nephrology, whatever, gastroenterology. All of those working in unison with the focus on CF. and how it's affecting the individual. I would love to see more effort put into that.
I love that answer. To be honest, like as a provider, I have a lot of anxiety about my patients aging with CF. And I worry about two different things, like doing too many screenings or doing too less or less than it should be. And I agree with you. I think having a primary care physician is going to become more and more important. I don't know anything about PSA, but I will probably have to learn. So the things, sometimes patients ask me, can you be my primary care physician? And I usually say, no, you don't want me as your primary care physician. I don't know anything about the screenings, like especially my non-CF bronchiectasis is in the 75, 80. I don't know anything about the screening. I'm a pulmonologist. So I completely agree. As people age with CF, I think we need to do better with partnering with primary care physicians and partnering very, very well with other subspecialties. You mentioned endocrinologists, gastroenterologists, and nephrologists. I mentioned cardiologists.
Yes.
And maybe other subspecialties that we haven't involved in CF care so far. Well, I will open, I think we're right on time, so I will open the floor to questions. Please send us questions via the app or step up at the microphone. And then we'll have more time at the end for the entire panel to take questions.
Oh, I'm getting the eye. Okay. Hi, David, thank you so much for sharing your story. This was a really compelling talk, and I appreciate you being here. Can I just ask a question of clarification? When you're referring to your transplant team, are you talking about the pancreatic islet cell transfer?
Yes.
Okay.
Yeah.
Wow, man, you're amazing.
Well, thank you, but I'm not amazing. I just, I'm just a human being trying to get through what's put in front of me. It's all about keeping the proper attitude and focus, and you just deal with it as it comes.
Wow. Well, thank you for sharing. I mean, you've been through so much. You're a real inspiration. So thanks for talking to us.
Thank you. I was just hoping.
You were escaping, right?
Yes.
Thank you, David, for sharing your story. I'm a pediatric pulmonologist, but I really liked your comment about the coordination with different specialists. And that's what I can't get my head around as like a CF doc. It's so hard to coordinate like with private specialists and different, in the healthcare system. Are there any things you could envision with like the CF care team kind of helping? Because we have care coordinators, so could they take on that role? Or is it something as, people maybe in the pediatric population, they're healthier and healthier. Is there other roles that we have to take on to make sure that these, the care is more integrated? Because I think that's going to be a key as people age, as you said.
Yeah. Well, one of the things that we're trying to work on right now, our CF staff is working on sending letters to primary care providers, trying to enlist cooperation. And they're also really pushing the idea of primary care providers to the patients. And I'm also on our adult patient advisory board, and we want to start working with the pediatric advisory board in getting that idea going early, so that when a patient transfers from pediatric to adult, they're already set in their mind that they're going to get a primary care provider.
Yeah, I think that's a great idea because I think within the CF world, we have a good CF adult team to transition to, but then those outside providers, I don't think have a lot of experience. So it's good to start it from that networking out.
Yep.
I think that's a great idea, actually. And having a patient, maybe a patient navigator, like that would help the patients with navigating like the complexity of their appointments and referrals and
Yeah.
coordinating visits.
Yeah, that's a great idea. And I think the advisory boards can go a long ways in helping that too, because you build that camaraderie with the adult patients, but also you can do that with the pediatric, parents that are on that board, and get them accustomed to the idea and kind of set the plan in motion before it even is time. So.
Hi, David. I'm from the UK, and I've been conducting interviews with older people with CF to find out about their experiences. Something I've been asking everybody is, what advice would you give to somebody who is younger with CF, who's perhaps worried or concerned about growing older?
I apologize, I couldn't hear you.
Try again. So, I've been conducting interviews in the UK with people who are over 40 with cystic fibrosis to find out about their lived experiences. And something that I've asked everybody is, what advice would you give to somebody who is younger with cystic fibrosis, who maybe is unsure about what it's like to grow older with CF?
So what advice would you give to someone younger with CF, knowing that they're going to live now longer with CF? What things would you do differently, or would you tell that person to do differently?
Well, I think the younger patients have so much more to look forward to. You can look at a guy like me that, I was born in 1961. Look at where CF care was back then. Still pretty much in its infancy. And through the years, as things have improved, but it's been, a lot of damage has occurred, like in my body or what's left of it. But the younger patients today have so much more hope because of all of the treatments, the, Trikafta, the research going on. Hopefully a cure soon, I was told when I was diagnosed, the doctor was telling me of all of the research happening, but he also said, you probably won't live long enough to see any kind of gene therapy. And my thought was, well, I've already lived far beyond my life expectancy, so challenge accepted,
Hi, thank you for joining us. I'm Julia West from New Hampshire. So my question revolves around how we think about how to individualize care as people get older and have more complexities. So when someone comes to clinic and we need to talk about their cardiac disease, their renal disease, their lung cancer screening, or whatever it is that we need to add to the mix, it helps to know the person and their health history really well. What we in New Hampshire have as a model is a shared care model where multiple adult docs are all seeing different patients kind of on a relatively random routine throughout the year. And I might only see each individual person once a year or even every other year at this point. It makes it hard to sometimes, I think, know the health history as well as I'd like to. There's value in the model that's evolved in CF of this really team-based model, but I worry that for older adults, that value may actually be diluted out by some of the other needs. So I'm wondering if you'd be comfortable, knowing your team is in the audience, if you'd be comfortable addressing that either from your own experience or from other kind of, individuals with CF with more complex non-pulmonary CF needs.
Well, first off, I would say you have to have a mutual respect. CF team has to respect me and understand me as a person and kind of know my tendencies or how I may think about things. But I too have to respect their position and what they do for my care. So I think it's important to tell patients that, it's normal to go see, if you're
having a problem outside of a CF issue, that it's okay for you to go to that type of specialist to get the care you need. Now, does it hurt? And of course, this is where that coordination of care comes in. But does it hurt to go to your CF team and say, hey, do you know a good cardiologist? Or do you know a good gastroenterologist? A lot of times they've already had some experience working with some of these subspecialties. Even if that tight-knit model of care is not there that we're all hoping for, they're at least going to be aware of them.
Do you mind if I re-clarify my question just a little? So within our CF team, we have multiple CF docs, and we all rotate with patients. Do you see one provider each time you go, or do you see a different provider each
Nope,
visit?
different providers.
And so within that, then, is that something that works well for you to really kind of see a continuously different pulmonologist, or would there be value in seeing the same person more often?
To me, it does not bother me. It does not hinder my CF care at all. They have a very good system of communication amongst each other. And like I say, I've been going to my CF clinic for, pretty much 30 years now, 29 years. So obviously there's been some new people come on board, but they're so integrated into each patient, I think, and what's going on with them. When they come in the room and they talk to me, you can tell they know everything there is to know. And so I have no problem seeing different providers within the CF team.
I would like to invite all the speakers here with us and open the podium for questions for everyone.
So I will read some of the questions that came through that we didn't have a chance to get to, but you are more than welcome to step up to the mic if you have any other questions that you haven't put in through the app. One question that came in, I think this was for our first speaker, Dr. Ramos. Is anyone looking at patient interest in lung transplant as the population ages? As the population ages, could we see a difference in desire for transplant, whether up or down?
I think that's a great question, and we have some older qualitative data that I'm going to be presenting tomorrow in a 9:30 a.m. Symposium session. Lung transplant, what the CF community still needs to know. And one of the themes from our interviews, we interviewed people with CF at the University of Washington who had an FEV1 less than 65% of predicted, so moderate to severe disease. And the study was done in 2016, and it was looking for unmet supportive care needs, and it was really palliative care needs, but didn't want to dissuade people from participating by saying palliative care. And unprompted, people brought up lung transplant at all ranges of the spectrum. And we found that people really were interested, even when they had normal lung disease, normal lung function or near normal lung function, to hear about lung transplant and understand how it's relevant to them. But themes that came out in additional research showed that people worry that they're too old to have a lung transplant, that they've lived longer than was predicted, and since they've outlived the life expectancy, why should they go through a painful transplant? And one of them said, oh, I think it only gives you 2 more years of life anyway, so why would I want to go through that? So we really need to give people accurate, up-to-date, CF-specific information about survival after transplant, which right now, median survival for adults with CF who undergo lung transplant is 10 years, and 1 in 4 adult CF recipients lives more than 20 years after their lung transplant. And so, you know, we have to give accurate information, but this may change, as I said, in the unknowns, that when older people with CF get transplanted, will we still have 1 in 4 who live 20 years? Is it all because they're younger when they get transplanted, or is it because they've navigated complex care for their entire life? And transplant is mostly taking pills. I mean, it's not nebulizers, hours per day. It's taking your medications as prescribed, showing up to your clinic appointments. And so I think that if we give people accurate expectations about transplant, then even as they get older and approach transplant, they may still want to consider this as a transplant option. And I know in Pete's clinic, it's sometimes thought of as a death sentence or, you know, the last resort. And I think that for kids that get transplanted, the outcomes are worse than adults who get transplanted. But it is going to be exceedingly rare for a kid with CF to need a transplant now, because they're coming to adult clinic with normal lung function. And as people get older, they may still need a transplant when they're in their 60s or 70s, just like people with COPD or IPF and stuff like that. So I think that we have to give people the right expectations about what's possible, and be careful to not bias them to think that it's definitely not a good option for them. So, and people right now, I think, do have that perspective of, oh, I've already outlived my life expectancy, so maybe I don't want to go through it. But I think that that's a false narrative, and I worry that they think I'm old because I'm 50, or I'm old because I'm 62. Like, you're not old. You're not old.
I was going to say, you should show them that pie graph of how 41% of transplant recipients last year were over 65. Right, they could be part of that if they want. Right, it's not just for young people.
It's not just for 30-year-olds.
Hello, Barry Plant, Cork, Ireland. Firstly, I'd just like to commend all the speakers for an absolutely excellent session, so thank you. My comment is, though, a slight concern around the models of care involving primary care physicians, because there are so many primary care physicians that you're going to dilute your CF patients. There's not going to be one primary care physician that's going to be the CF primary care clinician. And that then separates these things from the implications of what CF does to all of these things as well. And I don't think they're going to want to do it anyway, a lot of primary care. So I think the goal is either in this evolving model that we reach out and steal a primary care physician and embed them in a clinic as that kind of multidisciplinary team person so that they're part of it. Or it kind of goes back to why a lot of us did CF in the first place, because we're kind of part-time psychologists, dietitians, a bit of this, a bit of that. And maybe the challenge comes back on us, that whilst we may be born in pulmonary, we're just going to have to expand our knowledge set around hypertension and these other things by getting advice from the relevant stakeholders, but ultimately being the people who control it.
I'm going to answer you really quickly. So that works very well. I would love to have a primary care physician embedded in my clinic, but some of my patients travel 7 hours to see me. And half of my clinic travels at least 2 hours. So I love to have a primary care physician that I can partner that is 5 minutes away from their house. If they have an emergency, if they need to have a flu test or an RSV, they can see their primary care doctor. They usually reach out to us if there is anything CF related. We have a good partnership with emergency room, for example, from around the state. So that's where the benefit is. Or if we start lisinopril or something for hypertension, it's better for them to have a primary care physician that they can go to in a week, have another blood pressure, have blood work, manage their hypertension in a way that I cannot do 7 hours away. But that's a good point. I think there are pros and cons, and all depends on that personalized care. Where do you live? What state? Who is your population? Where are they coming from?
Mainly, I'm Mike Powers from Portland. Kind of a comment and a thank you for Kathy and Dave for being here. I took care of adults through the 90s before we had an adult center in 2000. So I started my fellowship in 88. And Dave reminds me of all the adult patients I took care of over those 12 years. And transplant was started around then, and survival was not good. And that was my lived experience because I was referring adult patients for transplant. And then luckily Portland, Seattle has a good collaboration, and I went to a talk that Kathy gave maybe 6-7 years ago, and the survival was much better. It opened my eyes, survival was much better. And I go to Great Strides every year, and I re-see my old adult patients, right, that I used to take care of 20 years ago. And I saw a patient who wasn't going to walk with his team because he was too sick and on oxygen. And I said, you know, the stats are better. Survival is much better. You need to go get referred. And he did. And he was transplanted at UW. And he is skiing on Mount Hood now. And he sends me, I'm Facebook friends with him, and he's sending all these pictures. So I wanted to thank Kathy for her enthusiasm and her science. And it made a big impact. And one of my former patients, I took care of him until he was 40. He got transplanted when he was about 58. So I really wanted to thank you. I wanted to thank Dave for being here, and I want to ask a question if he'll take a picture with me at the end of the session.
I have to thank you because that patient that you sent to us is such a phenomenal human and also participated in our Take on Transplant CF-specific lung transplant education website and told his story in an interview. It's a story transcribed on the website, and he talks about that conversation with you in his story, how it was life-changing. He never thought he was going to do transplant, and you said, just go consider it again. The outcomes are different, and he has 100% lung function. He is living his life. He is a poster child for why we do transplants, because when they work as they're supposed to work, it's really phenomenal.
It was amazing. And he never told anyone he had CF till he retired. He felt he would be discriminated against at work. And I remember we did a clean out when he was about 40, and he did home IVs, and he'd go to his car during a break, you know. So again, his life changed and things opened up. So yeah, it was really, really awesome story.
Hi, everyone. Thanks for the great talks. My name is Eric Drysdale. I'm a senior data scientist with BCG. More kind of question for the ML people, but related to as CF care changes. One of the hardest things anytime you're doing ML in healthcare is just that how medicine practice changes, and then the charts you're training the models on change. So how have you experimented with like how often you're going to have to retrain these guys, throw out old data? Are there any like critical junctures like, okay, we have these new antibiotics, we're throwing out the old models because it's going to mess up all the data? Just sort of question on that front.
That's a great question. Yeah, I mean, we're monitoring the performance of all the algorithms continually. I think with the registry data or electronic healthcare data, I think the signal change is very clear when there is a step change. And I think that acts as a prompt for retraining. I think with the home monitoring kind of predictive algorithm, I think we're in a position that once the trial is complete, then we'll be updating it continuously with new data. But it's a great question. Yeah.
There was another question for your team. Does or will the CF at Home app integrate with smartwatches to measure real-time vitals? Sorry, I think that's actually for Dr. Brown. Yeah.
Did you hear the question, Scott? Okay. He said that the at home or what CF at Home app has the option of connecting wearables, so be it heart rate monitor, steps, Fitbits, and integrating that into the app. But it's not mandatory. Is that right? Okay.
Okay, we'll do one last question. This one is for your team, for Lucy specifically. Could the algorithm that you described be applied to a widespread disease or a more common disease like COPD to gain traction, improve cost effectiveness before applying it to cystic fibrosis?
Yeah, so we're just about to open another study looking at non-CF bronchiectasis. So we're definitely interested in other conditions. So it'd be great to see. Do you want to add anything to that?
So the architecture, the ML architecture can stay the same, we think, between different closely related groups of conditions, but the training will be disease specific.
I was telling them I can't help myself. I'm going to have one more question, the last question, and this is also for Dave. We talk a lot about co-production of care, and when I introduced you, I mentioned that you are part of a network leadership team in CFLN. Can you share with everyone what your experience working in the realm of CF, but outside of your care has been, and any wisdom that you can share with other people? How can they get involved in working with the foundation and helping us as care teams, make progress in CF care?
Well, how can a person get involved? I would say, most importantly, just ask. If you have that interest, or if you see a patient that you think would be a good fit for work like that, just ask. That's how I initially got involved. Back, I think it was in 2007, my team participated in the LLC through the CF Foundation, and they asked me to be a patient partner in that. It was a one-year commitment. And here we are, 2023, and I'm still working with them on quality improvement projects. But I tell you, I absolutely love the work. And I have learned so much myself helping them. And through that, I was asked to be on community advisors. Then I was asked to be on the CFLN leadership team, the patient family partner leadership team. I helped form our patient family advisory board. To me, I love doing the work because it kind of gives this disease and all these struggles a purpose. And if I can do anything to help improve things for those following me, I'm all for it. So, does that answer all your questions?
Thank you so much. I think that was a perfect way to end. Thank you so much for attending our session. Thank you to my co-chair for making it run so perfectly. Thank you to the speakers, and a very special thank you to Dave for sharing your time and experience with us.